Right, welcome back everyone to Rocky Mountain Highlights 2021. I hope you've enjoyed our classical guitar renditions of early 80s and 90s hits. My name is Michael Chris. We're going to be starting session 2 now, and we'll be reviewing hot topics and the common, the rare, the new, the evolving. Please remember to use your chat function to ask questions or discuss points based on the talks presented today. And I do encourage the speakers to address those questions following the completion of their talks. Starting today, we have Dr. Ashley Lane. She is an assistant professor of medicine and transplant hepatologist at both the University of Colorado and Rocky Mountain Region VA Medical Center. And today she'll be discussing the practical management of NASH. Dr. Lane.
Thank you, Dr. Chris. Good morning, everyone. And I'd like to thank the organizing committee for allowing me to have the opportunity to speak to you guys today. So the focus of my talk is going to be on non-alcoholic steatohepatitis. This is very prevalent in the United States, as you guys know. So we'll talk about when to worry and what to do with these patients. I have no disclosures. So the goals of my talk today for you guys to understand. So we're going to discuss the spectrum of non-alcoholic fatty liver disease, so NAFLD, as well as non-alcoholic steatohepatitis, NASH. We're going to identify those patients that are higher risk with NAFLD. We're going to review how to perform risk stratification in these patients to guide our management in the clinical setting. I want you guys to understand and be comfortable on the use of non-invasive assessment tools in these patients, and then we'll briefly outline treatment strategies for NAFLD and NASH. So why is this an important topic? Well, it's an epidemic in the United States. So it's the most common cause of abnormal liver tests, and it's one of the most common referrals we see in our clinic. So just our general population in the US, about 20 to 30% of people are estimated to have NAFLD. 1 in 5 people with NAFLD are felt to have NASH, and 1 in 25 people progress to having advanced fibrosis and cirrhosis. So as you can imagine, very prevalent and also going to be a big burden on our healthcare system as well. It's also important to note, which we'll talk about later, that NASH, so steatohepatitis, is associated with increased overall mortality as well. So when we're talking about NAFLD, it's important to review the risk factors that are associated with fatty liver disease. So on the list to the left, you can review the more common risk factors associated with NAFLD. And just by quickly looking at it, you can tell that the majority of these risk factors comprise the metabolic syndrome. So people with metabolic syndrome are at higher risk for NAFLD, and metabolic syndrome is also highly prevalent in patients with NAFLD. Of these risk factors, obesity is the most common risk factor. And we know that the rates of NAFLD and NASH increase as patients' weight increases. So this graph just illustrates the risk of having NAFLD and NASH with obesity. And as patients' weight increases, and when they hit morbidly obese category, about 85% of patients will have NAFLD and 40% of patients will have NASH. So very big deal. So it's also important when we're talking about NAFLD to understand the spectrum of NAFLD. So it can range from just being fat, just isolated steatosis that accumulates in the liver without any inflammation. So we call that steatosis or isolated steatosis or NAFLD. It can go from just being isolated steatosis to having steatosis with inflammation. And over time, that can cause scarring. We call that steatohepatitis. And ultimately, the biggest thing we worry about is those patients with inflammation and scarring that ultimately progresses to having advanced fibrosis and cirrhosis. So it's kind of the end stage of NASH that we worry about, and we try to identify those patients before they progress to that point. So we know that patients with NASH, so steatohepatitis, progress to developing advanced fibrosis and cirrhosis at a higher rate compared to patients with just isolated steatosis. So this study looked at patients with just isolated steatosis or NAFLD on patients with NASH and the risk of developing cirrhosis over time. And as you can see, patients who develop NASH are at higher risk for developing cirrhosis. So 20% of patients with NASH in the study went on to become cirrhotic, whereas less than 4% of patients with isolated steatosis went on to develop advanced fibrosis. Really important to also note that steatohepatitis, just not isolated steatosis, is associated with a significantly increased overall mortality. And when I'm talking to my patients in clinic, I like to point this out. So most patients with NASH ultimately end up dying from cardiovascular disease compared to their liver disease. So when I'm talking to my patients, I say, you're more likely to die from cardiovascular disease compared to your liver disease, because the metabolic risk factors that increase your risk for fatty liver disease are the same metabolic risk factors that increase your risk for cardiovascular disease. So many reasons to take fatty liver disease seriously. So as we kind of move on to discussing the methods we can use to risk stratify and guide our management in these patients, I thought it would be helpful to do this by reviewing some cases. So how we think as hepatologists to take care of these patients. So here's a really common referral we get in our hepatology clinic. So we're seeing a 40-year-old female who was referred for abnormal liver chemistry tests. So in talking to her, you learn that she's morbidly obese, her BMI is 40. So just right off the bat, her risk of having NAFLD is 85% and her risk of having NASH, is 40%. She's diabetic, has high blood pressure and hypothyroidism. Her social history is really unremarkable. She doesn't drink any alcohol. Her mom did have fatty liver disease, still has fatty liver disease, so that's important to note in the family history. So in the labs, you get the important things to note. She has a mild hepatocellular liver injury. So that can be a surrogate marker for inflammation related to fat in the liver. Her platelet count is normal. Albumin and INR are normal, so markers of synthetic dysfunction. And you note that her A1C is 8, so her diabetes is uncontrolled. On viral hepatitis studies and other serologies you send off, everything's unremarkable or normal. On an ultrasound that you get, her liver is big and she has hepatic steatosis, but otherwise the exam's unremarkable, her spleen's normal. So what do we want to do next to risk stratify her and to guide our care? So there's a bunch of different things that we can do. One thing that we generally start with in our clinic when we're visiting with a patient is to do what's called lab-based scoring system. So the two more common things that we use are the FIB-4 score and the NAFLD fibrosis score. And there's various apps or calculators you can use to do this. We generally use the NAFLD calculator, and we find that helpful. And the FIB-4 score takes into account 4 things, as the name would apply. So the age, their transaminases, and platelet count. If the score is less than 1.45, then the presence of advanced liver disease, so cirrhosis, is unlikely. The NAFLD fibrosis score takes it a step further, so they incorporate the patient's BMI, whether or not they're pre-diabetic or diabetic, and then into account their albumin as well, so a marker of synthetic dysfunction. If the score is less than negative 1.455, then cirrhosis is unlikely. So these are really good at ruling out advanced liver disease. The negative predictive value goes up to about 90% with these scoring-based systems. So it can be a handy tool, when you're just seeing someone initially in clinic to help you risk stratify them. Another tool that we use in our clinic, so there's non-invasive measures of steatosis and fibrosis. The one we most commonly use is something called the FibroScan. There's also ultrasound guided transient elastography. And we can do this in the office. So at the VA, we have the machine, we bring it to clinic, we can bring it into the clinic visit and do one real time with the patient. Basically, there's a transducer that we put over the patient's liver, and that sends a shear wave through the liver. And depending on how fast that shear wave comes back to the probe, tells us the liver stiffness of the patient and gives us an estimate of their degree of fibrosis and also the degree of steatosis. We could also consider doing magnetic resonance elastography. So if we're going to get imaging for any other reason, say their ultrasound showed a liver lesion or we're concerned about something else, you can get an MRE. So how that works is radiology puts a probe on the patient's back when they're in the MRI machine, and that probe sends vibrations through the liver as well. And then the MRI software measures the liver stiffness by a spin echo sequence. So that can be done as well. These tools are less reliable with a couple things. Inflammation in the liver. So the probes or transducers can overestimate the degree of fibrosis or hepatic fibrosis with inflammation. The probe can't tell inflammation from scarring sometimes. So it can overestimate the degree of fibrosis. Hepatic congestion, so patients with right heart dysfunction can be less accurate, and then infiltrative diseases as well. So let's go back to our patient. So we're in the office, we're gonna calculate her lab-based scores while we're sitting there with her. So we pull up the calculator, we plug in her parameters, and then here's what the calculator tells us. So the NAFLD fibrosis score is estimated to be 1.928. So this tells us that the patient's risk of having advanced fibrosis and potentially cirrhosis is high. But this doesn't correlate with the FIB-4 score, so kind of discordant results. So the FIB-4 score suggests that significant fibrosis is unlikely. So what we would do next, so we have the FibroScan machine, let's get a FibroScan to help guide our management as well. So here's the patient's FibroScan. So the blue score is the CAP, so it's the degree of steatosis in the patient's liver. And then the orange score is the liver stiffness, so what the FibroScan is suggesting the patient has as far as fibrosis. So she has a significant amount of steatosis, and that FibroScan score, based on our scoring system, suggests that she actually has F4 fibrosis, so cirrhosis. But we always take this with a grain of salt when they have a decent hepatocellular injury, which again is a marker of inflammation. The probe can confuse inflammation for scarring. So this may not be completely accurate, but we already know going in, she has multiple metabolic risk factors and risk for having NASH and advanced fibrosis. So she is a higher risk patient. So what we could think about doing next as well is potentially a liver biopsy. So the AASLD guidelines suggest that we should consider liver biopsy in patients who are higher risk if we're concerned they have advanced fibrosis, if it would change our management or guide our care. And it also would be important, if we're concerned about a comorbid cause of chronic liver disease as well. So if you're looking them up and their serologies are abnormal, then it's also important to get a liver biopsy as well if it would change your management. So for this patient, she's young, she's higher risk. She has a high risk for developing progressive liver disease if we don't take action now. And if they have more advanced fibrosis, they're at high risk for HCC. So we want to consider imaging going forward to screen for that. So a liver biopsy would change my management. So ultimately, this patient did go through a liver biopsy and it showed NASH. So she had steatohepatitis, which showed some mild macrovesicular steatosis. She had some ballooning of hepatocytes, which is a marker of inflammation and liver injury. Her NAS score was 5 of 8. And she had stage 2 to 3 out of 4 fibrosis, so intermediate to early advanced fibrosis. So I think it was helpful to get this liver biopsy, and also important to note, like I was saying, that the transducer, the probe on the FibroScan, overestimated her degree of fibrosis, but did correctly identify that she did have more significant scarring. So now we've diagnosed her with NASH. She has intermediate to the beginning of advanced fibrosis. What do we want to do with her? So the most important thing is education. So I spent a good deal of time educating the patient on what NASH is, the implications of NASH, their metabolic risk factors, their increased risk of cardiovascular disease, and really weight loss is the most important thing to deal with this disease. So a lot of time is spent talking about weight loss. Our goal that I tell patients is to lose at least 10% of their body weight. But we know that if they lose at least 5% of their body weight, that will lead to stabilization of their disease. The fat will start going away if they lose 7% of their body weight. Features of inflammation will start going away. And if they lose at least 10% of their body weight, we do tend to see that their fibrosis can regress. That's why we say a goal of 10% weight loss. Diet is important as well. There's no one specific diet that should be followed to treat NASH. We generally say anything that leads to decreased caloric intake, so hypocaloric diet that allows them to lose weight is important. Hypocaloric diet, in addition to moderate intensity exercise, is shown to have sustained weight loss, so that is important. I tend to refer in these high-risk patients, refer them to endocrinology or have their primary care doctors help us control any metabolic comorbidities that are present. So we know that controlling diabetes, hypertension, dyslipidemia helps with outcomes as well. Limiting, avoiding alcohol or other risk factors for cofactors for progressive liver disease is important. And then if they have advanced fibrosis or cirrhosis, they are at higher risk for hepatocellular carcinoma or liver cancer. So we do institute imaging screening for that if they do have advanced fibrosis and cirrhosis. Other things that tend to come up in our visits or with providers as well are there medications that can be used to treat NASH? And unfortunately, there's no FDA approved treatments for NASH. So I tell them, if they have other indications for treatment of their diabetes or dyslipidemia, it's important to follow the guidance of endocrinology and primary care. I get asked a lot, what about surgery, bariatric surgery? So unfortunately, this isn't an established option to treat NASH specifically. The AASLD guidelines do say it can be considered in otherwise eligible patients who are obese, but the type of foregut surgery, the safety of surgery efficacy is not well established in this population. Then, of course, in the university, we could always consider clinical trials as well. So I wanted to contrast this with a lower risk case. So this is a really common referral I get at the VA. So 43-year-old gentleman who is incidentally noted to have hepatic steatosis on imaging done for other reasons. The imaging was otherwise normal. His history, otherwise, he's overweight, his BMI is 28, he has hypertension and PTSD, but his family history is insignificant. He doesn't drink alcohol. And then on routine laboratory testing, his primary care provider got recently, everything's completely normal. His liver tests are normal. So how are we going to risk stratify this patient? So the same thing. So we are going to plug in his parameters into the NAFLD calculator, our lab-based scoring system. This scoring system suggests that his risk for having significant fibrosis is low. We're going to wheel in the FibroScan machine and do a FibroScan real quick just to verify that he doesn't have any significant scarring. And the FibroScan shows that he does have a significant amount of fat, but no significant scarring, which is reassuring as well. So I think this patient, just has isolated steatosis. Their labs, imaging, fibrosis scores, FibroScan do not suggest the presence of advanced liver disease. So really, it's just counseling them on lifestyle changes, losing weight, telling the primary care provider to assess for any comorbid causes of metabolic issues, diabetes, high blood pressure, manage those if those pop up. But this patient is at lower risk to developing progressive liver disease over time. So in summary, in these patients with NASH, when should we worry? So we should worry about any patient with NAFLD and NASH just because their overall mortality is significantly increased and they're more likely to die of cardiovascular disease rather than their liver disease. So it's important to identify them and also negate these metabolic risk factors as well. We should particularly worry about patients with NASH and hepatic fibrosis. So these are higher risk patients. They're at high risk for progressing to cirrhosis and with advanced fibrosis developing HCC. And remember, it's important when we're seeing these patients, we can assess for those higher risk patients with hepatic fibrosis with those lab-based scores, non-invasive technology like the FibroScan, and then potentially biopsying those patients if it would change our management. And what should we do with these patients? So again, education is super important. So talking to them about the diagnosis, how we manage it, the importance of weight loss, and the impact on their overall health. Think about a multidisciplinary approach to their weight loss. So if you have access to a weight loss program, that would be helpful. It's really helpful to have endocrinology and our PCP colleagues control their metabolic comorbidities. And then in our clinics, we could consider clinical trials, referral to bariatric surgery in select cases. But again, know that this isn't the standard of care. Thank you.
Excellent. Thank you for that wonderful talk, Dr. Lane. Looking forward to having some more discussion, as I think that's a problem we're commonly seeing.